The next type of our drug interaction is between two drugs. The drug-drug interaction can be classified into pharmacokinetic type and pharmacodynamic type. For pharmacokinetic type, it affects our ADME, or the absorption, distribution, metabolism, and excretion. For alteration in absorption, we have the following. Alteration of pH that can happen with antacid and bisacodyl, which can result to premature liberation of bisacodyl. Another example is antacid and ketoconazole that can decrease ketoconazole's amount in the body. Another is antacid and salicylate can also result to decrease salicylate's absorption in the body. The next one is complex formation. Example of complex formation is with tetracycline given together with metal-containing drugs. This can result to decreased tetracycline absorption. Another example is fluoroquinolone with metal-containing drugs. It can also decrease fluoroquinolone's absorption. The third example is cholestyramine and digoxin. It can decrease digoxin's absorption. Cholestyramine with warfarin can also decrease warfarin's absorption. Penicillamine with metal-containing drugs can decrease penicillamine absorption. And sucralfate with levothyroxine can also decrease thyroxine's absorption. With decreased gastric emptying time, an example for this is atropine and antacid. So there will be increased antacid's absorption time due to the gastric emptying time delay. While if there is increased gastric emptying time that happens with nicotine with antacid, there will be decreased antacid absorption. With increased GI motility, such as with drugs like laxative or cathartics given with any drug, there will be decreased drug absorption. Adsorption of drug or a drug given with any adsorbent can cause decrease of drug's absorption. Interaction of enterohepatic circulation, such as your antibiotics given with oral contraceptive pills, results to decrease oral contraceptive pills absorption. The last one is the inhibition of the gastrointestinal microbial flora that is possible in antibiotics, and if given with digoxin, it can increase digoxin's absorption. The next one is alterations in distribution. This happens if displacement of drug from the protein binding site occurs. Example is warfarin with phenylbutazone and can result to hemorrhage. Glibenclamide and phenylbutazone can result to hypoglycemia. Oral hypoglycemic agents with aspirin can result to hypoglycemia, while bilirubin and salicylates can produce kernicterus. Phenytoin and warfarin can cause gingival hyperplasia. Tolbutamide with sulfonamide can cause hypoglycemia, while epinephrine and lidocaine can cause restricted blood flow. The next one is alteration in metabolism. So we have two types, the enzyme inducers and the enzyme inhibitors. The next is alterations in excretion. This happens if there is alteration of urinary pH, such as in salicylates and sodium bicarbonate and ammonium chloride with amphetamine. Both of these pairs have resulted in increased renal excretion of salicylate and amphetamine. Another is alteration of active transport. So it happens with probenicid with penicillin and probenicid with indomethacin. This resulted to decreased renal excretion of penicillin and indomethacin. Another is NSAIDs given with lithium salts and NSAIDs given with methotrexate. There will be decreased renal excretion of the object drug. Next one is quinidine and digoxin, amiodarone and digoxin, and corticosteroid with aspirin. The next type of drug-drug interaction is pharmacodynamics. Pharmacodynamic type can be additive, synergistic, potentiation, antagonism, and other types. For additive effects, that would be mathematically 1 plus 1 results to 2. Response is equal to the combined effects of the individual drugs. This happens with the following combinations: alcohol together with barbiturates, antihistamine, CNS depressants, chloral hydrate, chlorpropamide. So there will be additive effects because they are all CNS depressants. We have also flecainamide, verapamil, benzodiazepine and antihistamine, prazosin with beta blocker with calcium channel blockers, antidepressants with azithromycin. The next type of pharmacodynamic drug-drug interaction is the synergistic effects. Mathematically, it's 1 plus 1 makes 3 or more than 2. That means response is greater than the combined effects of the individual drugs. Example for this is the sulfamethoxazole and trimethoprim, which is our cotrimoxazole. And we have sulfodoxine and pyrithamine, our fansidar. The third one is potentiation. 1 plus 0 yields 2. It means that a drug with no inherent activity will enhance the effect of another drug. Example of this is our amoxicillin given with our clavulanic acid, ampicillin with sulbactam, piperacillin with tazobactam, and levodopa with carbidopa. Another type of pharmacodynamic drug-drug interaction is antagonism, where 1 plus 1 makes 0. That means a drug inhibits the effect of the other, or they cancel out each other. Example of these pairs are phenoxybenzamine with catecholamines, warfarin with vitamin K, heparin with protamine sulfate, opioids with naloxone, benzodiazepine with flumazenil, procaine with sulfonamides, epinephrine with acetylcholine, propranolol and albuterol, oral hypoglycemic agents with glucocorticoids, levodopa and antipsychotics, and tetracycline with penicillin. Other pharmacodynamic interactions also occurs with the following: aminoglycoside with loop diuretic, which can increase possibility for nephrotoxicity and ototoxicity. Aminoglycoside with neuromuscular blocker can also result in increased muscle relaxation or paralysis. Diuretic with any neuromuscular blocker can increase hypokalemia, causing increased muscle relaxation, producing paralysis. Diuretic and digitalis, when given together, can increase hypokalemic events, causing digitalis toxicity and paralysis. Diuretic with tetracycline has the possibility of increasing your blood urea nitrogen and affects the kidneys. So all of the mentioned drug interaction can happen if the patient have multiple drugs, so more drugs, more potential for drug interactions. If the patient also have multiple prescribers and the patient has risk factors such as old age, predisposing illness, comorbidities such as diabetes, asthma, and alcoholism. So as a summary, we can prevent these incompatibilities, both pharmaceutical and therapeutic, by reviewing our patient's drug history, reviewing our patient's risk factors, and avoiding complex therapeutic drug regimens. As a pharmacist, we can manage these different incompatibilities by being knowledgeable on the mechanism of actions of the drugs being used so that we can suggest a different drug for a significant drug interaction or any incompatibility that can happen. We can also consider therapeutic alternatives and we can instruct patient according to the appropriate timing of the medication to avoid incompatibilities. By using our knowledge, we can educate our patient, we can help them avoid the following or the mentioned discussed incompatibilities. Help the patient be educated so they can monitor events at home, their response towards the drugs, and they can monitor their health outcomes. That would be all. Thank you so much for listening.